Next up is an important panel titled Expanding the Workforce via Community-Based Providers, also referred to as lay professionals, paraprofessionals. The terms we'll get into actually on this panel, which I'm excited to address. I'd like to introduce our moderator, Dr. Stephanie Telecki. Dr. Telecki is the California Healthcare Foundation's Director of Learning and Impact, where she partners with the foundation's leaders and programs to optimize impact through learning and evaluation. She also leads the foundation's maternity care portfolio, which includes maternal mental health care and birth equity for Black mothers and birthing people. Stephanie and our panelists, welcome to the main stage. We're so excited that you're here to help us understand how these workforces will improve maternal mental health outcomes. Stephanie, over to you.
Thanks, Joy. So I want to just take a minute before we launch into our panel discussion just to ground us in why we're here at a maternal mental health conference talking about the topic of behavioral health workforce and the need for providers. So I just want to remind people that nearly half of all Americans will have a behavioral health issue in their lifetime. And in the US, nearly all of these providers are in short supply. And there are a lot of different reasons why we have a short supply. I'll just highlight a couple here. Chronic underinvestment in the behavioral health workforce, payment, really poor compensation for behavioral health providers, for maternal mental health, a lack of training on this specific topic. Shockingly, OBs and psychiatrists especially do not routinely get trained in this, even though it's the #1 complication of pregnancy and childbirth. And of course, COVID exacerbated all of this. So those are not all the reasons, but those are some contributing to the workforce shortage. And this shortage is really undermining people's ability to get timely care or care at all. 1 in 5 mothers or birthing people suffer from a maternal mental health condition, and 75% will not receive care. That is 75% of people suffering are not going to receive care in the population that we're talking about at this conference. So, that is really shocking. And especially shocking is that some groups suffer disproportionately, especially birthing people of low incomes and people of color, especially Black birthing people. So in short, we don't have enough professionals. We don't have enough specifically that know about maternal mental health. So we really need to expand the workforce right now, and we need to be thinking about the future. There's a lot of evidence that the types of supports that we're going to talk about today work. And so this panel is really about thinking about how do we get all hands on deck, and how do we utilize these different types of supports to really get mothers and birthing people the care that they need. Joy mentioned a little bit about the terms. I know this is lay professional, paraprofessional we hear, but I also want to throw out the idea of community professionals. And I welcome any of the panelists in sharing how they like to be referred to as well, because I think there's pros and cons to the different terms. So anyway, that's my little way of background. And now I want to let the panelists in a round robin, I want each of the panelists to very briefly introduce yourself with your name and organization. Tell us about the workforce briefly that you are here representing today, and really, include in that the kind of type of support that you offer. So I want to start with Christina, and then Christina, if you want to pass the baton to the next person, that would be great.
Thank you so much, Stephanie and everyone. My name is Christina Gable. I'm one of the co-founders of a company, Doula Care, which is based in and around Boston, Massachusetts. We're a 501c3 organization that contracts with healthcare entities to deliver community doula care at no cost to families. My pronouns are she, her, and I'll pass it to Kay.
Hi, everyone. Kay Matthews, Executive Director and founder of the Shades of Blue Project, also a licensed clinical health worker. I am based in Houston, Texas, but we provide services nationwide. Pronouns she, her, and I will pass it to Mia.
Hello, everyone. My name is Mia Edidin. I am the clinical director at an organization called Perinatal Support Washington. We're a statewide nonprofit in Washington state that focuses on a wide range of perinatal mental health services and training. So I represent peers, I represent licensed mental health providers, and I represent training and workforce development strategies for our state. And I'll pass it to Elizabeth Morrison.
Thank you so much. My name is Elizabeth Morrison. I am the co-creator of the Lay Counselor Academy, which is a course to train people without mental health degrees or licenses to do mental health counseling. And I'm a psychologist and an LCSW and an addictions counselor. And who's left?
I believe that's me. Good morning or good afternoon, everyone. I'm Elizabeth Salner. My pronouns are she and her. I am a project director. I'm a clinical social worker, and I work for an organization called CAI, or Ciccatelli Associates, based in New York City. We are a nonprofit that we work at the local, state, national, and international levels to help organizations improve healthcare and social services for historically marginalized communities. So both the work that we do and the way that we do it are unique. We partner with clients to understand their needs and strengths, and we develop customized strategies for their specific circumstances, and we deliver services that are evidence-based and practical. We've worked with community health workers in a variety of different settings, both in New York City and New York State, and we work with community-based organizations that hire and work with community health workers that provide maternal health and social services to communities where high disparities exist. And we've worked with these CBOs to train and provide technical assistance to community health workers through a support group training model to make sure that community health workers are trained to be able to provide support groups to parenting and pregnant people.
Thanks, Elizabeth, and thanks, everybody. I wanted to start off in our audience. We have certainly people who know of the type of support that each of you provide, but also some who perhaps are new to these different providers. So I really would love to ask a few questions around the evidence base for the effectiveness of the workforce that you represent. So I'm wondering if anyone, I think Elizabeth M. Morrison, you wanted to say a few things about this and really help us understand, especially honestly to the skeptics out there who might be wondering, this is a complicated space, and how can community professionals help in this space, and what evidence do we have?
Yeah, thanks, Stephanie. I think you used the word skeptic before, and I think often when we say we're training people to do mental health counseling, there's a little bit of like, how's that possible? And what about the license? And is that even legal? And and how could someone who doesn't have an advanced degree and a license possibly provide evidence-based mental health counseling? And there's actually decades of evidence that show that people without mental health degrees and licenses actually not only can provide services, but that the services are comparable. In fact, my team is 2/3 lay counselors, which is what we call folks who are providing mental health counseling that don't have the traditional degrees and licenses. And about 1/3 of my team are psychologists and LCSWs like myself. And we're all believers, or we wouldn't be doing this. But the first time I showed that, my own team, our own data that shows that the results are absolutely comparable, one of the people on my team was like, why did I go to grad school? So there is a little bit of but what I'll say is that lower income countries, in particular South Africa and India, have been doing this for decades. I see Mia's nodding, and Christina. I think there are a lot of people who do know this. I think the US has been a little arrogant in not looking at these decades of research that show that not everyone can do it. We would never say everyone can do it. It's highly skilled work. What we're saying is the degree and the license is not actually what makes people effective, which any of us who have seen a bad therapist know. And now there's a lot of evidence in the US. Just in the last 10 years, we've had a lot of emerging research. And like I said, my team has their own data showing the high effectiveness of lay counselors providing mental health counseling.
Thanks, Elizabeth. Mia, anything else to add here from you?
Yeah, I think that, some of the different types of providers that we work with, we do a lot of training around home visitors. We also do a lot of training with peers. And there's a couple things I'd like to say around that is that, we know that actually training home visitors and having comfort in talking about emotional well-being and being able to recognize signs and symptoms and being able to know where to refer as well actually improves the, emotional and mental well-being of families in the first year. And so training home visitors who are often a trusted source who are already working with families is a really vital way of actually augmenting and increasing access to care and not just referring into an overtaxed mental health system. The other thing that I think I'd say is that peer support is a complete service. It's not necessarily just an augment service to, other services as well. And that we know that peer support has a wide range of evidence base in terms of comfort of use, access, outcomes in terms of, supporting one's emotional well-being. And then we also know that it can really be a stepping stone for those that do want and maybe need a higher level of care, So I think it's really important to recognize that emotional well-being is a huge spectrum, and some folks might really need, a licensed mental health provider and might need, medication services or might want those things, right? And there's a lot of folks who would really benefit from accessing peer support services, as an example, only or in conjunction with other types of services. And there's a wide range of evidence to support that.
Thanks, Mia. I wanted to dig in to just one thread here before going on to our next question, which is the idea of the skill that you need to know when you need to escalate. I know that's a concern that many providers have, and in our very sort of degree conscious healthcare system, that's it's also a legitimate concern. When do you know that you're kind of out of your league and you need to send the patient or the person somewhere else? So I wonder if any of you could speak about any aspects of the training that address that concern, which is a real concern.
I'll take that question. I think it falls in line when we think about evidence-based. From the perspective of someone who works in the community across the board, I'm thinking more from a practice base. When you're doing this work, you honestly know when it is time to escalate. We are typically, as someone who leads support groups and works directly in community, we serve in 3 tiers. So we have our peer support model, we have the licensed clinical social workers, and then we have the psychiatry mode. And so we know that there's levels to caring for folks. And so evidence-based has to be coupled with the understanding of practice-based. This is something that automatically triggers you to be like, the support group is great, but maybe not right now. You need more help or more support than what could be offered. And so I think that's where we're coming up short with thinking that because you're not a licensed professional that you don't know this. But when you work with people, you do. This is a part of being in the behavioral health space. It's understanding the person that is presenting before you, that they're not going to be like the person before or after. They're going to present in a way in which they need. And so it is our job to understand that and be able to react to that. That is what actively doing this work is, whether doesn't matter what stage you're in, whether you are not licensed or a community health worker, a doula, you're working with people. So you're able to, something triggers that inside of you to be like, okay, this person is out of the scope of mine. Who can I bring in? Because at best, we all have networks as well. So that is how that comes into play. We're not trying to solve this issue by ourselves. We have networks of folks that can fill in the gaps where needed.
Right, excellent points. And your point about it does take a village in a lot of these kinds of, and a lot of different skills. Anyone else want to add anything there on the sort of triage, if you will, situation?
Yeah, I would love to add in. Thank you, Stephanie, and thank you, Kay. I think that the other aspect is knowing who to go to when CHW or that like counselor needs support. And I think it really puts on the emphasis on that supervisor, who is that licensed clinician there, or who other supervisors in the organization to provide that support. And part of what we did when we were training CHWs was helping them to also recognize the signs and symptoms of something that would need to be escalated. and then being able to have those conversations with their supervisor that were continuous. So not just a, every so often meeting, but maybe meeting once a week or every other week to check in to see how all the clients are doing, or participants or patients or whomever they were, to really check in and make it a continuous process, not an outlier to say, oh, only this one person is experiencing symptoms that need to be escalated.
Yeah, those are excellent points. I wanted to transition now to talk a little bit about something that I hope will be of interest to our audience, especially the decision makers and policymakers and others in attendance. I would love to hear from you about what is standing in the way of broader uptake. We know that there's an effectiveness here. We know we have a shortage. Why are we not seeing broader uptake? What are the challenges to widespread implementation? And what specifically do policy and delivery system leaders and Medicaid programs, et cetera, need to understand about the potential solutions for implementation? So I'm really asking here, when you are getting up every day and going to your job, what are the things that keep, where you tear out your hair and you think, oh, if only ... So fill in the blank for us. And I want to start with Christina, and then I hope others will chime in.
Well, in that sense, I'm surprised I have any hair left, but I do, thankfully. This is really the biggest question for me of what all of us are here to talk about today in our respective fields. So again, I work with doula care and specifically community doula care, and that is a huge policy issue that's coming up in several states, if not nationally, in some of the maternal mortality and birth equity minded federal bills. So what I want to encourage folks listening to understand is that this is a profession that is evidence-based. To the question that was made earlier, the evidence has shown time and time again, we don't need another randomized control trial on doulas. The evidence is there and the history is there too in cultures preceding us, and Black granny midwives, and in so many other circles that have shown us the way in doing this work. Passage of a bill to reimburse that work is really in some ways the beginning of what happens after that in terms of implementation. So I'll be brief, but one thing is, we don't have the sheer number of doulas that everybody who might want one can get one. So there's a lot of talk right now about workforce development and investing in workforce development. What I feel I bring to the table with our organization, Accompany Doula Care, is that we really work primarily with the workforce as sort of a professional home or a hub, if you will. And we help to address the gap between a trained workforce, a trained, ready and willing and passionate workforce, and actually getting to the direct service delivery that families can benefit from. And there's a lot of exit ramps, if you will, down the highway where people can kind of fall off. And one thing I talk a lot about is, yes, we need to train more doulas, but if we don't have meaningful and equitably paid jobs and positions available to them, on top of creating their own business, which there's barriers to that too, it needs a lot of help if you've ever filed an LLC. We need to translate their time and resources that they put into training, which could be financial, or maybe they got a scholarship and it's not financial, but it's everything else, the sheer number of hours they took to train, what they might have done for childcare during that time. Did they have to take off of work to do that training? So there has to be a very quick turnaround between the training and a ways to capitalize or return on the investment of the training. There also has to be a lot of mentorship that follows that as well. And then my third bucket, and I think we'll go into this a little later, is you also have to be in a culture and a climate that respects the work that you do. And if you can't get to the hospital because, the triage nurse or whomever is saying, the visitor policy stipulates that you can't come in, or et cetera, then you also can't capitalize on all your training and expertise, because you can't go and accompany your client when they most need you, and for what is in many states the bulk of the reimbursement for you. So
Yeah.
I'll pause there because I could go on for several hours.
Yeah, no, that was super helpful. And you hit upon a lot of parts of the chain that are challenging, everything from having people be able to find out and come into the field, get trained, get mentored, and then actually practice what it is that they're trained to do. And that has a lot of barriers too. So really helpful comments. Any others want to chime in here with just any aspects of barriers?
I guess I would say that for lay counselors, I think the biggest barrier is actually conceptual. I think that there has been such a bright line that's been drawn at the therapist's door. Like, it's so complicated what happens behind this door. No one else could possibly do it. And it's so complicated, we can barely tell you, there's been a lot of that. And so I think what we run into is really high risk aversion. This idea that it's dangerous somehow. What about trauma? What about suicide? It's, so dangerous. And those are all conceptual barriers. Those aren't, billing barriers. They're not reimbursement. Those are there too. But these are really the biggest barriers. And so often we say to people, how dangerous is it to have people already disclosing suicidal ideation to your medical assistants, to your call center, to the case manager who is so good at their job that they elicit such a high level of disclosure, because people don't trip and make disclosures. People make disclosures because the person in front of them is very skilled and is engaging in evidence-based counseling strategies, whether they know it or not. That's why people self-disclose, especially with things like substance use or things that are highly stigmatized. So we have people in our systems all the time getting those disclosures that we haven't decided are doing mental health counseling, that we've kind of denied. We've framed them as referrers. Your job is to refer. Your job is to refer to what? The 6-month wait list? To the therapist that maybe this person doesn't even want to see because they've already built trust with you. To the person who doesn't reflect them in all kinds of ways, whether it's like being from the community, racial, ethnic, queer, that's not reflective, that they feel alienated by. So I think a lot of what we bump up against is, thinking.
Yeah, the barriers of our own limited thinking.
Our own limited thinking.
Yeah. And Elizabeth, when you and I chatted before this panel, I think you had a really important, I actually wrote down that, it's the risk of doing nothing. We act like there's all this risk on one side. Oh my God, they're not going to triage appropriately. They're not going to be up to speed on blah, 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 blah. There is a huge risk to telling somebody, you can see somebody in 6 months, and that risk includes death. It's not, doing nothing is not without risk. That's a decision, and that's a decision we make frequently in our current climate. Any other barriers, things that you want to share? Again, think about the ripping your hair out. If only this would happen or that would happen. Elizabeth, Salner, or Kay, or Mia, any other things you would highlight?
Yeah, I was going to just add, kind of jumping off of what Elizabeth Morrison said, just that we think that, they need a specific intervention that only a licensed clinician can offer. When what we really hear from folks is they want a place where they can feel heard, where they feel validated. And in the case of support groups, where they can have that sense of connection with other people that have experienced similar things to them. And community health workers and other lay counselors are often folks that have the same lived experiences as they have had or similar, right? And so that they can relate to them as well, where, sometimes we think, with a degree, with certain training that licensed professionals have had, that makes them qualified. Where when we kind of really take that step back, we see it's really that human connection that's what's most powerful and impactful for folks.
Mm-hmm.
And Elizabeth, I would just say really quickly that the evidence base for therapy, the evidence base for therapy is that it's the human connection that is the driver of all health outcomes. So in therapy, that is the curative factor.
I think that I would just add, we often put sort of the onus on whatever the professional or the provider to decide what should happen for the family or an individual, which is a very paternalistic approach to providing care for someone. And what if we put the sort of shifting, sort of how we approach services to having a conversation with a family about what would be supportive and what is their next best step and what are the things that they would find, helpful at the place that they're in right now. And that might be mental health therapy or talking with their doctor. But I think that it's really important to recognize that a lot of folks do not have a positive association with talking with their doctor about these very hard to talk about things, or talking with a mental health provider. That individuals have had very negative experiences with our mental health system. They've had negative experiences with our medical system, and that's not the trusted source to receive support. And so when we say, if you have had a positive screen, then I have to refer you on to a mental health professional, when the family has had no indication that that's the next service that they would like to access, what we're saying is that we know better than you. We know better than you what you need, and your desired service is not appropriate or accessible. And that's not the way that we think that care should be provided. We think that there should be an accordion approach to services where there's a range of services that folks can choose from. And sometimes it starts with going to the support group, or it starts with meeting with a peer. And it's actually a developmental process to say, you know what, I'm still really struggling. You know what, I'm really having a hard time. My symptoms are getting worse. I'm starting to see that it's harder to go to work, or whatever it is that the individual shares. And in conversation with whatever care provider they're talking with, they can say, what should we think about doing? These are the range of services that are available out there. What would be the next step? And having someone to walk along with someone. And it's not for the purpose of moving them into mental health care, but it's really helping them navigate all the different options that are out there.
And
Yeah,
the
those are
evidence
great points.
base is around
Mhm.
preference, that patient preference is related to patient adherence. So when we don't centralize the preference of the patient and the family, then we also start having really high non-adherence, for which we often blame the patient and the family for.
Yeah, yeah. I wanted to dig in a little bit to this concept of sort of the viable career for the people who do this work. I know there's the issue of in California anyway, that some of the doulas are being now paid similarly to an OB. But when you look at it, doulas have fewer patients. They don't have the volume, so the OB provider is making their income on the volume. Often the doula or other types of professionals have far fewer patients because of the time that they're spending with each individual one. So there's a tension there, certainly in a space where there's different turf wars and things like that are just, we have to acknowledge. I'm curious how you think about the barriers that exist, or the potential solutions around just, can someone do these different professions and actually have it not be a side hustle, have it actually be what they do and that they can live on it? And what are the barriers there in both our thinking, to your point, Elizabeth, what barriers do we need to jump over for that? And what are some of the barriers, otherwise, and sort of increasing this workforce and making it something that people can see as a viable way to not only have a meaningful life, but also a way to put food on their table and pay the rent?
I can start responding. Oh, sorry, Kay, did you come off mute? Oh, okay, sorry. Please chime
Okay,
in
we'll get to
after.
you next. Okay,
Yeah.
we'll go to you next, Kate.
So, right, the first place people's minds go when we ask this question is the level of reimbursement. And I want to applaud some of the Pacific Coast states for really, really kind of setting the bar even higher. Washington and California have among the highest reimbursement rates right now. But I think it goes back to my question of, yes, volume is important still for a doula if you want to make this a full-time career, especially if the reimbursement rate is not where it should be. And that's where I go back to organizations like ours, where we don't have any full-time doulas. I know some doula organizations like Sister Webb in San Francisco, for instance, do. We don't, because the clients and members who are requesting our services are asking for a large diversity in race, ethnicity, and language concordance. So we try to keep a broader staff, but that means more limited clients for each person. Though I will say that if I were thinking about it as in what would make this my full-time job, I almost think you would have to do it in conjunction with other people, because for somebody to be on call full-time as a doula, as their only income, you're talking about never leaving town, always having childcare at the last minute, not having any other commitments in your life, and that's where I go back to, yes, we train people, but if we don't help them become the LLC or find a backup or find a mentor or find a network, this is a really difficult job to do in complete isolation. And you would have to really turn over or figure out many aspects of your life in order to do so. And that's what actually limits my ability to take more clients as a doula that I've been for 13 years now. So again, the communal aspect and the investment and all the overhead cost and other people that you need there to support you to do this work would be my answer. And I'll pass it over to Kay.
Thank you, Christina. My piece that I'd like to add to this is, as a barrier in looking at this particular question, we have a lack of the value on this profession. This is why we are always talking about cost and lack thereof, and who's getting paid what and how they're getting paid. And with that being said, that's why licensing in so many cases becomes a barrier as well. What does it change to become licensed if you're still going to be underpaid and not given a livable wage? And so we are overthinking a lot of these things that were initially designed to save people's lives. Some of us have been doing this too long. We are missing the mark on that. A lot of these things were alternatives because folks were not getting the care that they needed. I think that continues to be lost. And we talk about doulas and midwifery and how these practices have come into play. There's history behind it. So we're thinking about evidence-based. The history, it continues to repeat itself because most of us don't know it. And so when we are looking at big picture here, that becomes the barrier right there. We don't value the profession. And so we'll go back and forth on who should be paid what and how much. But a livable wage should just be the standard for where we sit right now. And it's just not that. And so when we think about the perspective of like the billing codes and who's paying for what and things like that, what about the folks who can't bill? As a community-based organization, I am one of those folks. So looking at what are all the moving parts to a lot of this, but for me at the forefront, it's no value on the profession itself. You know that it's needed. You actually know that that it does work. And so now you want to govern it. But it's not on the end of the person who is doing the work. And having to meet all of these now requirements for something that they've naturally been doing to save and have better birthing outcomes. But want to do it where they're able to have sustainability for themselves while doing it. So we don't care about the person naturally that's doing the work. It's about how they're doing the work. But the person who's doing the work also cares about that, but they need to be compensated. So that's the biggest barrier here when we're talking about billing and things like that, is the lack of value on the profession as a whole.
Yeah, super important points, Kay. You set me up nicely for sort of a nice segue to, I wanted to get into a little bit about sort of the billing and payment, and this gets a little bit in the weeds, but they're really important weeds for a lot of the reasons that Kay just highlighted. So, we know in the health space in the US, it always makes sense at some point to follow the money, because the money indicates what our society values, what the system, the bigger system values, and can usually, there's all kinds of incentives out there. So then you can start seeing why different entities are behaving the way they are, because people are going to behave the way they are. in track with where the reimbursement goes. So I would love to hear from you a little bit more in depth. Some of you have touched on this a little bit, but what specifically can you tell us about payment and billing for your particular type of professional that you represent? How, and I know we have people here from different states, and that a lot of this is state by state, especially when you're talking about Medicaid. So specifically, how is billing working or not in your state to support these kind of providers? And, please feel free to speak to both commercial and Medicaid. Yeah, just curious to know a little bit about, I'm sure this is a part of your daily existence that does result in hair pulling. So yeah, I don't know who wants to start, but this is a really important topic for trying to align and support these types of professionals.
I can say a little bit. So this is where I think we need, again, more investment in organizations or groups that are trying to do this work. It's very expensive for our organization to hire a billing specialist. We also have other costs like HIPAA compliance, IT systems, security, HIPAA compliant online platform, those things, because we operate as a group. And I always say, we default to putting the intervention into systems where before us, exclusively clinical workforces have existed. And if I was a clinical workforce, and I had a 5-minute conversation with a patient to adjust their medication, I could bill for that. And there might be somebody in my office who decides if we can up bill for that, right? And there's a credentialing person maybe in my system who's going to walk me through all the credentialing, all these things that larger clinical groups and institutions take for granted. Smaller community organizations like ours who are being asked to come to the table don't have the resources to pay for. So, and I saw Elizabeth come off mute as well, so.
I think what I was thinking about when you were sharing, Stephanie, is obviously like we're all pulling hair on this one for sure. I'm very ambivalent about whether being a billable provider is desirable, because I think there are other therapists, who are in the audience here, but it has driven practices that are in direct opposition to the evidence base. Once you're a billable provider, we move the computer into the room. And even as a therapist, when the empathic connection and listening is actually the biggest correlation to whether someone even gets better in your office, now 80% of therapists type at some point during a session. When we know from the research that you can't actually type and listen at the same time. And once you open a device, people perceive that they're not being listened to as well. They're perceiving that accurately, but it just means all of the things that we've told ourselves about why it's okay to type while someone is talking to you is BS. It's just BS. And so that's the licensed clinician in any field, is they type during sessions, and listening is pretty low, and you spend as much time documenting after the session as you did with the patient. So we know for primary care physicians, it's something like, I think the average is like 3.5 hours a night or something. Their entire lives are putting your kids to bed and then doing your EHR, which is unsustainable and is part of why we see the massive shortage in people leaving the field. And that's true as licensed therapists as well. I spent years putting my kid to bed and doing EHR at night. So I think it drives in the public spending space. So in Medicaid, Medicare, and Medi-Cal in California, which is where I am, it also drives this intense focus on assessments. So we drown people in paperwork. It's like you've waited, 4 months to see me. You have all this fear about talking to a licensed therapist. It's like you finally come and you're hoping that you'll get a chance to talk. And I spend the whole first session typing through your session and giving you tons of paperwork to fill out. Assessment. Those were always meant to be screens given in a waiting room. They were never meant to displace that really high quality person to person time, making somebody fill out forms. And once you're billable by any, even commercial insurance, that is the track that it takes. But there is a disproportionate impact on people who are publicly insured. They do the most paperwork. There is the most focus on diagnosis. There is the most typing during sessions because there are the most intense documentation, standards. So would rather not see lay counselors become billable providers. I would rather see this continual movement toward value-based payments and bundled payments of some kind, so that we're paying a particular amount for a team or a particular amount per month per patient. And then that organization gets to configure that team in the way that makes sense around the patient and the family. So I just have a lot of fear about what licensed clinicians do in the billable world, and having that contaminate our world, like us, all of us on this.
Yeah, really good points, really thoughtful, and perhaps opposite of what some people in the audience might think that that is the goal. Any other comments on this, Mia? I see you've come off mute. Please chime in.
I'd love to hop in. I also feel like this is a complicated thing to figure out. We're a community, statewide nonprofit, and we provide several different types of peer support. And one of the things that we're doing is, we are becoming a behavioral health organization so that we can apply for, Medicaid reimbursable peer support services. And one of the reasons that we're doing that as an organization is because grant funding is boom or bust, and it often will sort of go towards like whatever the current funders thinks is like the thing that they want to fund. And so again, it takes really the control and the power away from the folks that are providing the services and interacting with the communities and interacting with the families who are saying what it is that they need or what is it the services that they want. And it puts it in sort of like, what is the trend, right? What is the thing that funders want to support? And so we're really trying to, as an organization and thinking about sort of our own sustainability and how we do the work that we value, is think about how do we have a consistent revenue? How can we anticipate our revenue year after year? And sort of moving away from only grant funding or one-time or 3-year funding, which means that we can, ramp up a really beautiful service, and then that funding might go away. And so I really love some of the points that you've talked about, Elizabeth, because I think re-envisioning how we bill, right? Because it sounds like that's still billing, right? Or that's still, contracting with maybe a, a Medicaid agency or a state service or something, state agency or something like that, I think is really needed. But in the short term, right, as an organization who really wants to ensure that peer support is available to people that would want it, we are trying to work within the systems that we have. And I will say that, I think Kay had brought this point up earlier, a lot of community-based organizations can't access that Medicaid reimbursable billing, right? Because probably intentionally, many, community-based organizations aren't providing formal mental health care services. And so as we sort of approach this, we're thinking about this as one type of peer support that we're providing, because it also requires, as you've mentioned, Elizabeth, that the individual, consents to a certain type of treatment and meets a certain need, right? A medical need, a medical necessity, because they're engaging their healthcare insurance in it. And we know from the folks that we serve that there's a large percentage of people who don't want to access services in that way, even if it's to access peer support services, right? They don't want a diagnosis. They don't want to engage their health insurance. So we're providing, again, these multiple ways, even within the peer support realm, to offer services that people want, as a way to provide sustainable support and have an organization that's sustainable.
Thanks, Mia. I wanted to ask, when you think about, I don't know the mix of your practices and the supports that you offer, commercial versus Medicaid. I'm wondering if anyone has any comments, observation, things they want to mention about that, or even just to speak to Medicaid in your state and, barriers there. So the different types of payers and your payer mix. Elizabeth, did you want to say something there? Oh, I saw you off.
No, I didn't want to jump in first.
Yeah, Mia, I see you.
And I just spoke, so if anyone else wants to hop in, I can definitely speak to this. I think that the sort of credential and licensing approach is is a catch-22 for all the reasons that we've already talked about. You know, and, you know, when, you know, mental health care is provided, you know, through your health insurance and, right, you have to have medical necessity, then, you know, the Department of Health becomes the one who decides who can provide services in your state and who can't. And so in Washington State, there's several really exciting things that are happening, including creating bachelor's level, you know, mental health license. We have had certified peer support in Washington State for a long time, but we're actually like re-envisioning what that credential will look like to give it a little bit more independence. It'll still likely need to be sort of under a, you know, behavioral health or substance use disorder focused program. But we're doing some work to sort of make those more accessible. And one of the things that the new credentials will also sort of support is, you know, the commercial health insurance, you know, doesn't have to provide reimbursement for any type of professional that's not licensed by Department of Health. And so by creating these, you know, sort of licensees in Washington State, what we're also doing is opening up the avenue for folks to get peer support if they have commercial insurance. Because I think a lot of what we're all talking about here is peer support, at least what I often is talking about, is peer support through Medicaid, right? Because there's already a pathway for that. But there's currently very few pathways for folks that have any of the commercial insurances to get peer support through their health insurance benefit. So there's some moves in Washington State to try and really support our very overtaxed mental health care system by thinking about what are all the different types of providers that could be providing care, and thinking about like what are all the steps to operationalize that, which in our current structure is to create like a designation, right, a license and a credential, which I know, right, opens up a can of worms in terms of the piece around, there are so many people who have been doing this work forever, right, that a licensed mental health professional is really a commodification of an interaction that human beings have been having for, you know, ever, you know, and that don't need a credential or a license in order to provide high quality care. But within the systems that we work in today, in order for those to be reimbursable through, you know, health insurance, it needs to be a licensed provider through Department of Health.
Right. Yeah, really good points. We have certainly a diversity of states represented here. And Kay, being a Texan myself, I'm curious. The state is not widely known for its enlightened thinking on women's health and mental health. And I'm just curious if you have any insights or things that you'd like to share around, you know, there's state operating in a state that's very different from, say, Washington or some of the other states that are represented here. Any comments you'd make on that realm, especially with regard to Medicaid, where there was not Affordable Care Act expansion, et cetera?
I was trying to stay quiet, Stephanie, on that subject. You know, being in the often not so great state of Texas, it becomes a struggle for women's health just across the board. And if you put mental health in the mix, there's an even huger struggle of really wanting to, as a community-based leader out here, really wanting to work with entities like Medicaid and insurers to understand the role of community leaders and how we are their gateway connection to their clients. So these are your clients, they're our clients. How can we collaborate? What does that actually look like? And it tends to be a struggle because of policy barriers, right? And how do we fight these things when we're continuously fighting for the betterment across the board? Each state is different. And for us, we tend to do things in this state before bigger things come into play, right? So if nationally things go into effect, believe they already been in effect here in Texas. And so we're always battling the right thing to do from a person perspective. And we just don't do that here. And so having the year expansion of Medicaid for the postpartum period, it sounds like a win, y'all. But when people were not even able to take advantage of the 6 months that they had, what's an additional 6 months to do? And so it will be years before actually the year of extension of Medicaid to actually have its true effects on our community. Because of right now, We don't even know how to use, we didn't know how to really navigate when we had the 3 to 6 months of coverage. And so a year, it may take us a year to even get to that point where we understand that. And so I think when both Elizabeth and Mia have said, some of us want to know billing and some of us don't. It's like, do we, but we're making these decisions based on sustainability of the work that we do also. And so that comes into play. That becomes the biggest factor, to be honest with you, as a community-based organization. That becomes the biggest factor. How are we going to sustain? So when you are working and looking towards sustainability, you do start to look at other options and other ways to bring into the fold. And then sometimes those other ways tell you it's not even worth the hassle. So Elizabeth, I thank you for bringing that up, because that sometimes tends to be what it is too. We want to build, we want to bring in this extra income because it's work that we're already doing. And so I think that one of the biggest solutions that we often talk about, but maybe not in the context that we need to, is our collective efforts together. What does it look like to not continue to work in silos so that you understand? People tell me all the time, okay, I can help you build. And I'm like, well, what does that mean though? Like, what actually does that mean to put into effect and to get it going up and going? Where again, it lends to sustainability, because that's the biggest part. The other part of that is we're going to do this work regardless. And so all across the board, wherever the funding comes from, it has to be looked at that way too. So who is going to continue to put this at the forefront? So we're not always looking for ways for sustainability in this maternal mental health space. That's another piece of that as well. And so it's a lot, but it's not that we don't want to work with the entities where we can build and do all of those things. It just tends to be more than the work itself. And so you got to pick and choose. So for me, I'd rather just serve the people and continue to figure it out, and work towards others understanding that we're tired of figuring it out and having to do the things that we don't want to do that is actually taking away from the work that we are doing. So yeah.
Yeah. I feel myself getting frustrated though, listening to you, in the sense of that the system, if the system knows you're going to do it regardless, that's not an incentive to pay you what you should be paid. And that I find frustrating.
Can I add something to that, what Kay said?
Yeah, please do.
I think that I think the most frustrating thing for me when we're looking at other people doing mental health counseling outside of licensed folks is one of the things that you talked about at the end there, Kay, which is the way we've dealt with sustainability is organizations like community health centers or hospitals or first responders or CBOs, like organizations that already have people that are paid for doing work with other people. And they come to our academy and they learn how to add mental health counseling to their scope. So we have a lot of peers who come through that then, yes, using your lived experience. Also, everyone with lived experience is not a skilled peer specialist. So peer specialists are skilled counselors separate from their lived experience. So we feel quite confident that we can add mental health counseling to their scope. And same with CHWs. The majority of people who come through our academy are CHWs. So that's kind of how we address sustainability. It's not like this whole new workforce. We don't care if you call them lay counselors. We just want to support people that are already in your organization doing really skilled work with folks, to feel more confident in the mental health counseling they were probably already doing. To Kay's point, I feel really mixed about that, because on the other hand, I think what's happened is people who are already doing a lot of mental health counseling, when they come to the Lay Counselor Academy, we spend the first 3 weeks saying that what you just did, that's an evidence-based therapy strategy right there. That's what we call it. Okay. Like, we just are kind of like validating and amplifying the stuff they're already doing and labeling it. And then we add more and add more confidence. But there is so much unpaid labor happening in our human service organizations when it comes to mental health counseling. It's invisible, it's unpaid, it's unacknowledged. And because it's in lower paid positions that are unlicensed, it disproportionately is women of color that are doing unpaid, unacknowledged mental health counseling. So I don't want to be a part, like with our work, we worry about that all the time. Like, are we part of like making this worse? They're even doing like a higher level of stuff and they're still being unacknowledged and not, reimbursed for, or not being paid in their organization for this. So there's a real tension for us, I think, in that.
Yeah, absolutely. I know we are staring down the clock here, and I want to sort of give each of you the last word in the sense of going around and around robin and really what is sort of a main thought, and I know there's many, but you know, to especially the decision makers that we have in the audience, you know, what is a main takeaway that you really want people to leave with for the providers that or the professionals that you represent? And especially, you know, we've touched on a lot of different ways on equity, inequities across states, inequities across different subpopulations, inequities in payment. So to the degree that, you know, that also comes up in what you're sharing, I think that would be helpful, because this particular field and topic is just riddled with inequities, and we've spoken to a lot today. So I guess I don't know if anyone is prepared to start and kick off the round robin, but you know, what is one key thing that you really want the audience to take away from your presence on this panel?
I can start us off, and that is, you know, at every stage of building this out, and we've heard a variety of perspectives on what that looks like today. I think one thing I try to say a lot publicly is, let's not try to take a health equity solution and retrofit it into the systems that failed and got us here, such that we needed that solution in the first place. So at every stage of the process, I am always asking, why are we doing this? Are we doing this because that's the way we've done it, because that's what we do with clinicians, or because there's a fear or a distrust, which we've talked about in all of these roles, and we want to exert some kind of control over it, as if that can be, you know, exclusively preventive, you know, and so, which often ends up being punitive, to be honest. So let's not retrofit. Let's actually think of something new and get there. So.
Great. Let's see, who wants to go next? Elizabeth Salner, you want to?
Yeah.
Yeah.
I think, you know, we see time and time again just how these inequities really are affecting maternal health, and especially maternal mental health. And so we see just that how important CHWs are in providing that support and care, that because they're from the community, because they're able to hone skills through training and through support of supervisors, that they're really able to build that trust and reduce stigma, especially around mental health, for people to engage in services. And so they really have been and can continue to be an important role in our maternal mental health workforce. So I think we need to continue to uplift their voices and their importance and role in maternal mental health.
Thanks, Elizabeth. Mia, you want to go next?
I would just say quickly that I think that there's a couple of comments that I'd like to uplift that some of my panelists have shared. Things like, you know, folks that are non-mental health providers are like the resource and referral folks. And I think that, you know, really sort of, you know, giving folks the opportunity to do the work that they're already doing and gain recognition and support, and also get paid for it, is so important. And I think, you know, Kay mentioned something around, you know, we know that this works, so we don't need more, you know, more kind of information and research. We need to, you know, sort of, you know, allow folks to do the work that are doing it.
Thanks. Kay?
I would just say valuing the role that we all play, because we all have a role. It's not this top down, it's more so bottom up. We need to shift. So if no one walks away with anything other than that, is valuing the role and position that we all play.
Great. And let's see, Elizabeth Morrison.
I think that I guess the thing that I would want to leave people with is just to get out of the thinking that we cannot meet the mental health crisis that we're in and the mental health clinician shortage doing the same thing we've been doing. And that there are other people that can do mental health counseling. We're not saying everyone can do it. I always feel like I have to say that to my fellow clinicians. We're not saying everyone can do it, and we're not saying it's easy. It's highly skilled work, and other people can do it. And so to really invest in the people who are already skilled and already touching your patients and your clients, to give them more support to provide mental health counseling. So instead of saying, let me put you on the list, they can say, thank you for telling me that. Tell me more.
Thanks, Elizabeth. Great point to end on. And thank you all, panelists, for a great discussion. And thank you all to the audience for listening in. And I'll turn it back over to Joy.
Thank you, Stephanie, and thank you, panel. It really struck me as a time where I think no one can really argue that these workforces are not necessary. It's really about implementation, where the rubber meets the road. And I'd like to challenge some of the players, as we call them, the 4 Ps, who are in decision-making positions to help with implementation, to think about what they can do. In particular, organizations like the State Medicaid Directors Association and the American Health Insurance Plan Organization, AHIP, to come together and listen to these voices and create pillars for reimbursement and support. Is it through new payment strategies? Is it contracting arrangements, and what do those look like? It's really time to take it to the next level. And I appreciate the panel so much. It was like sitting in a living room together with all of you. Thank you, Stephanie. I now would like to invite our audience to share what resonated most with you by going to Poll Everywhere. It's POLLEV.com/MMH, and we'll pop up those instructions on the website here. You can also text 37607. You can find the instructions here at the top of the screen, and type in a word or a phrase that resonated with you. So we'll take a moment now. You can go to pollev.com/MMH to type in your word or your phrase. Or you can text 37607. Text MMH to 37607 to add your word. If you want to add a phrase, use an underscore, so treatment_access, for example, to add your phrase if you want to add more than 2 words. Great. Well, we invite you to continue to add words to this word cloud. We will publish these word clouds in the photos section in the Whova app after today's conference.